Welcome to another episode of Judgment Date, a series of programs that we've been doing, as it were, to get people over the lockdown, to inform them of what is going on in all sorts of areas which have been affected by this unprecedented COVID-19 pandemic. And today, it's a great pleasure for me to introduce to you Professor Shabir Madhi, who is the Professor of Vaccinology, I've got it right, at the University of Witwatersrand. So I wonder whether I could ask you first, you've written quite a lot about the question of this lockdown, and I just want to sort of, in words of one syllable, would you be able to just essentially justify, I think, your argument, which is that the lockdown as we have it at present is really counterproductive?
Correct. So I think the lockdown has served its purpose. And now the question is, what is the next stage of this outbreak in South Africa? Where we're not at and where we don't have the luxury to try to aspire towards is what we call containment. And that is to prevent the spread of this virus in South Africa. That sort of stage opportunity passed us by before the lockdown was actually implemented and before we started to see sort of sporadic transmission in the community. Now, the lockdown had very specific purposes in terms of buying time, really, for healthcare facilities to be better equipped to deal with the increase in number of cases, which is going to happen over the course of the next 2 to 3 months. The healthcare facilities weren't equipped on a number of fronts. In addition to which, the way it sort of assisted in that regard is that by having the lockdown and sort of reducing the movement of people, you are less able to transmit the virus from outside of your household. So there's sort of a slowing of the rate of transmission, but it doesn't prevent and it doesn't eliminate the virus. So that's where we are right now. So the next steps, clearly a lockdown is not sustainable in any country, let alone South Africa, with its huge problems in terms of the economy, in terms of the social impact it has. So the next stage now, where we are, is basically one of prevention and one of mitigation. And that is really the next phase of the epidemic and where we need to be planning for.
Could I just ask you, just because you've said a lot, and I just want to try to put this in terms that I understand and you understand, you're the expert. What I wanted to ask was, in relation to the lockdown, the way, I mean, we started very early, but it does seem to me, would I be right, or would you be agreeing with Professor van der Heever's argument that actually what happened was that the R factor initially went down because we suppressed the expansion of the virus in the middle class areas, but actually as soon as it got into the townships, R went over 1 again, which goes to show that the lockdown is just not a useful mechanism for a country of our kind.
Yeah, so unfortunately not. So unfortunately, the reality is that you can only calculate R, which is the reproductive rate of the virus. You can only calculate it if you've got some level of stability in terms of the number of tests that are being done in the population. If that sort of ranges anything from 1,000, which was at the beginning of the lockdown, up to 10,000 at the end of the lockdown, but as an example, what happened in South Africa in the first 2 weeks of the lockdown, we were actually doing fewer tests than we were doing each day than before the lockdown. Before the lockdown, we were doing about 2,500 tests. In the first 2 weeks of the lockdown, that fell to under 1,000 tests per day. In the last few days of the lockdown, that increased to 10,000 tests per day. Now, the 40 cases that were being diagnosed at a time when you were doing 1,000 tests per day is pretty much the same as the 400 cases that you were diagnosing when you were doing 10,000 tests per day. So it's impossible to actually calculate the R0 or the RT, what we call the reproductive rate, the effective reproductive rate under those circumstances. So that's what we're seeing in terms of the data is completely an artifact of the testing that was being done at the period of time.
And because the testing has been inadequate, as I understand it, therefore, it's all very well me debating with you whether R was X or Y or Z.
Exactly.
Actually, it's completely inaccurate because unless you've got really rigorous testing, you can't really calculate these things.
Correct. You need to have rigorous testing and you need to have stability in terms of the rate of testing.
But then can I ask you, why then can we confidently suggest, is the issue of, let's say, the lockdown at level 4 counterproductive for medical reasons, or are you basing this almost exclusively on economic reasons?
Certainly not. I'm a medical profession, And my
Yes.
priority is the well-being of South Africans. That is my priority. And I'm basing it on medical reasons. So what is the reality? Today, the National Institute for Communicable Diseases on the NICD website just released data in terms of tuberculosis. Now remember, tuberculosis in South Africa kills over 60,000 people each year, 60,000 people. About 1/3 that are not living with HIV, 2/3 that are living with HIV. The outcome of tuberculosis is highly sensitive in terms of getting them onto treatment as early as possible, right? If you delay treatment, your outcome is worse. What the NICD reported on today is that the number of people that came forward for testing in the 5 weeks of the lockdown was almost 50% less than in the 6-week period before the lockdown. It's not because the lockdown is cured people of tuberculosis. It's simply because the mobility of people is being affected, the functioning of clinics is being affected, and people are not coming forward to be investigated for TB. In addition to which, the number of people that were confirmed to be infected with tuberculosis, that have active disease, right, that has actually declined by close on to 30% during the 5-week period of the lockdown compared to before the 5 week of the lockdown. So that is one example. Another example.
If I could stop you there for a moment, just let me test that. I understand perfectly what you're saying. And in fact, there are a whole range of implications I think we can draw from what you're talking about, which is, I assume that TB essentially is located in poorer communities rather than wealthier communities. And if I might then be quite blunt about it, in black communities, not white communities. And so we spend a lot less time worrying about this. I find that an appalling conclusion to come to, not your argument, just the fact that it so depresses me. But let me ask you this. If we then do have a real kind of exponential increase, as everybody's suggesting we will, in the pandemic, and we suddenly find ourselves flooded with more people coming to the hospital because of the virus, it's not going to help the TB people either, because the whole hospital services will be overrun in any event.
Okay, definitely. And the lockdown is not going to achieve a reduction in transmission on its own. What is going to achieve, so when we talk of flattening the curve, right, all it speaks about is having the same number of cases, but over a longer period of time. It's got nothing to do with reducing the number of cases. And that is a misconception that exists, right? Government and politicians believe that flattening the curve means this virus is going to go away. That is anything but the truth. In fact, this virus is going to continue causing problems for at least the next 2 years, at least the next 2 years. We're going to have waves of outbreaks happening for the next 2 years. Now, the point that you make is pertinent, right? The purpose, what we need to do is see what intervention, what strategy best lends itself to being able to slow the rate of transmission of the virus. And it's by slowing the rate.
We agreed on that right. The object here has to be slow the virus. And going back to your earlier question about TB, that would allow the hospital services at least to be able, if I could call it, to service those people desperately in need because of TB. One can't argue that they are less deserving of hospital care than
Correct.
People who are affected by COVID-19. I agree with you. So how do we slow it down then?
Right. So those are the non-therapeutic interventions. It's not through a lockdown. It's not through level 4. It's not through level 2. You can go immediately down to level 1, and you'd be able to have the same sort of outcomes as you would at level 4. Right? And unfortunately, the only thing that's going to work in terms of slowing the rate of transmission of this virus is not government policy at all. Right? The only thing that's going to work is citizens of the country abiding to the non-therapeutic interventions that have been proposed. Things such as avoiding overcrowded situations, a ban on mass gatherings, things such as wearing a non-surgical face mask so that if you are infected, you don't transmit the virus, things such as hand hygiene and physical distancing. That is a sum total of the armamentum that we've got at our disposal in terms of trying to contain the rate of transmission of this virus. There's nothing else.
Why are virologists and epidemiologists the world over suggesting in many countries we shouldn't open up too quickly because we'll get a massive explosion yet again? Those countries that did have a lockdown and did manage to repress, let's say, the spread, they still have it, but so why are they arguing that then?
Right. So just remember, they're coming from a very different perspective and a very different dimension as well. So the reality for most Northern Hemisphere countries where these arguments are being made is that The purpose of their lockdown is very different from the purpose why South Africa went into lockdown. They went into lockdown in the midst of when they were experiencing a peak in terms of the epidemic. We went into a lockdown at an early phase of the epidemic, and it's got different objectives. So you're not dealing with the same objective in terms of why you're going into a lockdown. But now the reality also is that all those high-income countries, right, if you look at the mortality rate from other communicable diseases, it's negligible. It's close on to less than 100 per million of the population for all of the other communicable diseases combined. Right? The reality in South Africa is that tuberculosis alone has a mortality of 1,000 per million population. Right? So we are looking at different contexts. So what they're looking at is they're in a comfortable situation of having been successful in dealing with other communicable diseases. Other communicable diseases are not a threat to them. They've got a luxury in terms of the economy being able to survive sort of blows to the body in a sense. They've got a luxury that their citizens are basically able to be supported with grants of into the thousands of dollars each month. We do not have that luxury in South Africa. So I think the context is really important. Now, are we going to experience a rebound? We're not experiencing a rebound right now. What we're experiencing now is a natural trajectory of the virus. And there was no way that we were going to change this.
Exponentially.
Well, how quickly it grows is completely dependent on the non-therapeutic interventions, right? When we were in level 5 lockdown.
But can I ask you this? Are you suggesting that if we simply went back to our pre-COVID-19 era and simply said to people, act responsibly, social distancing, hygiene, etc., that we would have this would have no greater effect on the spread of the pandemic than if we had some restrictive measures in place, however we define those?
So there's a classical example, a case study here, a real-life case study, and that is in Nordic countries. Sweden was the only Nordic country not to go into a complete lockdown. In fact, they were too liberal with their policies initially. They were allowing mass gatherings of up to 500 people, right? Denmark, Finland, all of the other Nordic countries went into lockdown. What is the difference between the two? The epidemic basically has sort of panned out in exactly the same way.
Well, no, it's not entirely true.
I'll tell you why I'm saying, just give me the only difference between that is Sweden has got a higher mortality rate.
Yeah, it has.
Right, they've got, right, but let's put it into context. They've got a high mortality rate. They've got about 134 per million of the population. Denmark then comes in at about 54 per million of the population. Now that's a 2.5-fold increase. At what cost? At what cost did Denmark actually achieve that nominal, what I consider to be a nominal reduction in terms of mortality?
It's a massive reduction, 160 to 50.
No, it's not. It's not. When you've got 1,000 people per million of the population that are going to die of tuberculosis, it's all context specific. It's really context specific. When we're saying that tuberculosis, when we're saying that COVID-19, so the models right now, and I think it's important to put a context, the models right now tells us that with everything that's happening right now, we're probably expecting about 48,000 deaths in South Africa from COVID-19. 48,000 deaths. Not in a single year, not in a single way.
As I understand it, by the way.
Well, it's 48,000 to 75,000. So 75,000 is the upper end, right? But that's deaths that are going to occur over a 2-year period. What I'm arguing is that the number of TB deaths, right, without factoring in the excess TB deaths that are going to happen, right, is roughly about 60,000 on its own each year. So in this 2-year period, we're going to have 120,000 deaths. If we're not careful, right, that 120,000 is going to go to 150 and 160,000. The excess number of deaths just from tuberculosis alone is going to exceed the total number of deaths from COVID-19. Now, another dimension. So what has happened again? Children are no longer being immunized. The immunization rate in children has dropped, right? Now, children are at no risk. They're pretty much almost close to zero risk.
But that is not entirely true. We're starting to discover that children are being affected this in various different ways.
Well, the reason why you discovered it.
Statement, Professor.
No, the reason why you discovered it is interestingly because it's such a rare occurrence. It's like it's likely that.
But it's only started. We don't know.
No, we do know. There are 50,000. So Italy is very unique. Italy is unique in terms of anyone that dies, they would sample them, right? They would test for COVID-19. It's one of the few countries that do post-mortems on everyone that dies. as of the 5th of May, there had 30,000 people that died of COVID-19. 30,000, not one child. In the middle of April, there were 125,000 people with COVID-19 in the United States. There were 3 children that died. All 3 children had serious underlying medical conditions.
We must be careful about making these because this disease, whether you like it or not, is unprecedented. You have to accept the modesty of medicine that we don't.
It's not unprecedented.
Right.
It's not unprecedented. The Spanish flu from 1918 was, COVID-19 is about 10 times worse than seasonal influenza.
Yeah, but it's unprecedented in the modern era. In the modern era.
In the past decade, in this century,
the past 100
certainly.
years. Yeah. But let me put this to you. Okay, let's just deal with it. I want to come back to tuberculosis and I want to talk about the children. As I indicated right up front, I'm with you. I'm on the same page with you in relation to TB. So let's take that off the page for the moment and agree that we should be equally concerned about this, if not even more so. But how does it help the TB patients if we overrun with COVID-19 patients at the same time? Neither will in fact get better because we won't be able to treat vast majorities of both of these. And you know as well as I do that it is more likely that there'll be people in the townships and in the rural areas who can't get the same private health care as wealthier people can. So what I'm saying is, surely one can't be, cavalier is an unfair word, but one has to be extraordinarily careful about sort of making the assumption, well, it won't make any difference. Surely,
I'm not saying a lockdown on its own is not sustainable, firstly. So I think a common starting point needs to be.
This is not a binary. This is not between a lockdown. Right. I'm trying to suggest to you that the debate should not be between a total lockdown or even a level 4 lockdown, which is not much different to a level 5 lockdown, to be perfectly blunt.
Yeah.
In fact, it seems to me it's given rise to all sorts of strange regulations, but be that as it may. On the other hand, it's not between that and some sort of libertarian view, surely, that we just allow everybody to do their own thing. Surely
no,
there's a via media here.
Without question, there's absolutely no way that I'm advocating going back to pre-COVID era. There's absolutely no way, right? That would be, I mean, I would undermine my standing in every regard if I would be brainless to suggest that, right? And Trump might suggest it, and I do not fall into the same basket as Trump to start off with. What I'm saying is that the only way that we're going to get through this, and we're going to be able to assist in terms of slowing the rate of reduction of the virus, right? It's not through government policy, right? It's only through the action of citizens. And citizens need to understand what they're in for if they don't adhere to those non-therapeutic interventions. If citizens don't buy into that concept, right, we are in big, big trouble.
But we, right? We don't live in a world where we allow people to make every choice for themselves. We have rules of the road. We don't allow people to say, well, if you want to stop at a red traffic light, you can. There are rules that we impose in all forms of society.
And society pays a price for not adhering to the rules, like South Africa having the highest accident rate on the roads. So society pays a price.
Yes, I agree. But we also don't enforce the rules properly.
Exactly. So it's the responsibility of government. The responsibility of government would be to introduce those rules, right? And those should be rules, right? Well, unfortunately, right now, it's recommendations and it's not enforceable in a sense.
Right? Let me give you... sorry, carry on.
But government needs to make sure that they've got the necessary capacity in terms of ensuring that people are abiding to that. Now, let's take an example of what resource we've got, right, which is being misused as far as I'm concerned. So we've got 28,000 field workers that are doing these home visits, right, to screen for people that have got signs and symptoms of COVID. Now, from a scientific perspective, that is a futile exercise, and we can discuss why it's a futile exercise.
Well, perhaps you should explain that to people listening to our discussion. Just briefly.
Okay, so the reality of this illness, this virus, is that there's a 2 to 14 day, what we call an incubation period, right? Where even if someone is going to become sick, they become infected, and the virus sort of needs to use the body's machinery to replicate, to reproduce, right? And it's only after that 2 to 14 days, so say roughly at about 5 days, that people start becoming symptomatic. Right? And then those symptoms can be ongoing. Now, when you go to our house, so there's 28,000 field workers, there's 14.5 million households in South Africa. The average field worker would need to take responsibility for about 500 households, right? For that sort of a strategy to be successful, you can't second guess when someone in that household is going to be symptomatic. You would need to repeat a visit every 2 to 3 days. That one field worker who's responsible for 500 households will need to repeat a visit every 2 to 3 days to actually find the people that are symptomatic, which is not plausible. Right, so repeating a visit every 2 months is a futile exercise, because during the 2 months, the people are going to become symptomatic, they're going to be infectious, and they're going to be infecting other people. Right, so the entire model of assuming that you can do household screening using field workers is flawed. What needs to happen, rather, is that people need to be educated. You've got the symptoms, these are the clinics within easy reach of you, and you need to present yourself to those clinics to be tested. Right? And people need to be explained that it's not to punish people and put them into a lockup, into isolation. That is what's happening in KZN. Right? That is an incorrect way of approaching the problem. So, like I said, these 28,000 field workers rather can be deployed to every taxi rank in South Africa. They can be deployed into the city centers. They need to be roving about. And people are not wearing the mask. They're not maintaining social distancing. These are the people that need to be educated to actually transfer that knowledge to those other individuals as to why they should be doing what is being requested of them. Right? And that would be a much more efficient and effective use of these field workers in terms of trying to assist us in controlling the rate of transmission of the virus.
So when people read, for example, in many countries in the world, and in fact, interestingly enough, I know again you can tell me these are developed countries, but let me just take that as an example, that I listened to a very careful interview with Professor Paul Romer, who's a Nobel Prize laureate in economics, and he was saying, unless you do proper testing and tracing, you know, you'll always still have a sick workforce, and you can't have a sick workforce and a healthy economy. So are you suggesting that we actually do, that we're failing in that regard, and that's where we should be focusing our attention? And if so, how would that work out? I mean, what will we, if you were the Minister of Health now, how would you advocate that tracing and testing should operate?
So unfortunately, there comes a tipping point in an epidemic when it actually becomes sort of, again, futile to be doing that sort of a strategy. That strategy works at an early phase of the epidemic or sort of towards the tail end, and you're trying to... Pardon?
We're too late now.
So let me tell you why we're too late on a number of fronts. So the first problem that we've got in South Africa is the National Health Laboratory Service are on record as saying that by the end of April, they would be able to do 36,000 tests within a 24-hour period. Okay, that is what they told the country they would be able to do, right? We're in the middle of May. Right now, they can't even do more than 10,000 tests per day with a 24-hour turnaround. What is happening right now is that when someone gets tested today, there's a 5 to 14-day waiting period for that person to get a result. By the time the person gets a result, right, in fact, that person is almost no longer infectious. It's an academic exercise to have tested that person. It assists us in terms of identifying how many cases that we were able to identify, but it doesn't tell us what happened yesterday, because those cases that are being reported today are not cases that were sampled yesterday. They are cases that have been sampled about a week ago. So what's the problem here? A person is most infectious in what we call a pre-symptomatic period, which is about 3 days before the symptoms start, and for 5 to 7 days after the onset of symptoms. After that, the person becomes less infectious. When we're doing testing of a person just on day 2 as an example, right, what happens effectively is that already we need to trace up to 5 days equivalent of close contacts of that individual. Each individual has an average of about 20 close contacts per day. Right, so even if you're able to get your testing done and get the result within 12 hours, for each individual, you would need to basically follow up about 120 close contacts. To be effective with that strategy, you need to follow up at least 80% of those close contacts, at least 80%. And that is not just tracing them, but actually going out and physically seeing that they're not symptomatic. South Korea achieved it.
But if you have 28,000 people?
That's my whole point. Already at 500 individuals, right? When you need to follow up 6,000 contacts, right? Assuming that you get the results quick enough, right? You don't have the resources to be able to do that. Before the lockdown, we weren't able to even get to 20% of the close contacts in South Africa, not even 20%. South Korea achieved what they achieved. New Zealand achieved what they achieved because they were able to contain simply because they were able to get to more than 90% of the contacts, and they were able to put them into quarantine. Do the conditions in South Africa and in any of the sub-Saharan African countries lend itself to that? And unfortunately, the reality we need to accept is a blunt no. Not when.
Okay, so now, but that creates, well, that's why then when you come back, we can't do that. You're almost asking the government to fly blind because they're
no, so we're not, that's not it.
All you're offering, which maybe, I'm not suggesting it's that there's anything else, but it's very depressing, is that you've got to rely on ordinary people just to be responsible. And that's a pretty risky strategy.
That's the only strategy that is within our armamentum in terms of slowing the rate of transmission. But there is another option for testing. So it's all about why you're doing testing, right? And so when you're doing the PCR test, it's nasal swabs. You're doing it for a very specific purpose in terms of identifying infectious cases, putting them into isolation, and putting their contacts into quarantine. That's the reason for that. But if we want to understand which communities are hotspots and where we need to focus in terms of our intervention, you don't need to do a PCR test. You can do what we call a rapid antibody test, where you can literally do it at a household. You do a systematic sampling in the community across the country, and you can pretty much do a geospatial mapping of where are the hotspots in the country. Right? That is something that.
Why aren't we doing that?
Well, that is exactly what we need to transition to. That's exactly what I'm arguing. That our testing needs to be goal-directed. Right? We can't use one modality to answer a different question.
Got you. Now, let me ask you, just press you on 2 points that you made. Take children. And I have to concede, obviously, that the evidence is overwhelmingly such that even if they do get infected, there are very few of them, right? So let's accept that. But they are vectors for transmission to others. And in the township areas, will they not be infecting older people?
Okay, so let's take it in 2 parts. The first thing is that
you don't get it.
The first thing is that children are equally likely to be infected with this virus as adults. There's no difference in terms of them being infected.
Are they equally likely to infect others?
So they're equally likely to be infected, but they don't develop severe disease. They rarely develop severe disease, and they even more rarely die. Are they? Right. The answer to that is the evidence at this point in time indicates no.
Why?
So unlike seasonal influenza, well, there's 2 studies now, right? In fact, there's 3 studies, but the one that probably is the most informative is the one from the Netherlands, where they looked at different age groups, and then they looked at people that were infected as index cases and who did those people infect, right? Included in that were children that were infected. We don't know what the source of that is. What they showed was a linear association in that adults are infecting adults. Adults are infecting children. Children are rarely infecting adults. And in fact, adults are more likely to infect adults in the same age group, which doesn't come as a surprise because adults of the same age group are going to be in the same social circles, in the same sort of network, right? But the summary of that particular study, surveillance, and it was really well done, was that when you look at children as being the index case, they rarely infect adults. Now, the whole concern about children being a vector of transmission is purely based on an extrapolation from seasonal influenza. With seasonal influenza, without question, children are an important vector of transmission. Right? Our concern around COVID was premised on our experience with seasonal influenza. But we also know with seasonal influenza, children under the age of 1 die from seasonal influenza. They're one of the highest risk groups for seasonal influenza. So these are 2 different viruses. We've learned more. We need to recalibrate our understanding of the role of children as vectors of transmission, and they're not vectors of transmission, major vectors of transmission.
Can you be confident that extrapolating from a Netherlands study, which in the light of the fact that I did some research for this particular program and had a look at that in the light of the fact that you had cited that earlier, can we confidently suggest that that study is equally applicable to South African conditions?
So let's just unpack it a little. Okay, there's a biological basis to explain all of this. Right? Now, so let me take it, let's take it step by step. So children get infected. They don't develop severe disease. So there's something happening in a child that prevents them from developing severe disease. That something is not anything else other than their own immune system being able to respond to the virus and control the replication of the virus. Now, the major driver in terms of viral infectiousness is the viral load, the amount of virus at the back of the throat. Right? The more virus you've got, the more infectious you are.
Mm.
The more virus you've got, the more likely you are to develop severe illness. Children are not developing severe illness. The reason they're not developing severe illness is their body is controlling the virus. Like when they're hospitalized, they've got the same viral load as an adult that's hospitalized with COVID-19.
Let me take a different one. Okay, now, okay, so because I'm running out of time, so I just want to ask you two final questions. Take restaurants. There's a lot of evidence that suggests that because so many people are asymptomatic, you open up restaurants and somebody can cough, gets into the atmosphere, and before you know it, and it's happened quite across in many, many parts of the world that people then are affected. So you prepare to take risk.
I wouldn't be advocating for opening up of restaurants. I wouldn't be advocating for opening up of mosques. I wouldn't be advocating for opening up of churches. So definitely not.
So there are things to restrict. There are things.
Certainly. Any gathering of more than 10 people outside of schools, I certainly wouldn't be supporting it.
Okay, got the point. Sorry, then I misunderstood you. So you're not arguing this mad libertarian idea that, which by the way, some politicians are, which is very but you're saying that there are a whole host of controls here which are utterly useless, and actually you do have to look to people's better nature, and then in certain instances where there's sensible controls, like I'm not going to open up the religious gatherings or have thousands of people congregating together, because that would be a terrible vector for the transmission.
Exactly, and that's what happened in South Korea. They sort of came out of they started opening up the country, one nightclub, and you got 100 people that are infected. And that's exactly what you want to avoid. And we're going to need to avoid that for the next 2 years, not for the next 2 months.
Okay, then can I just ask one question? Because you obviously know about vaccines. So what is your view? I mean, and it's a very unfair question because nobody really knows, but I mean, is there a possibility that we will find a vaccine for this awful disease?
Yeah, I'm highly optimistic. Highly optimistic. I think
if I could ask, because we need to.
Sure. So on multiple fronts. So firstly, the technology that's been used. Usually it takes 5 to 10 years, 20 years to develop a vaccine. But people have been able to adapt the technology that they've used to produce other vaccines, even other coronavirus vaccines, and they've adapted that technology to actually develop a vaccine against COVID-19 now. Right? So the technology is there, and that has allowed us to expedite the process. And now there's been non-human primate studies, challenge studies that have been done, which shows protection when actually challenging these primates after having been vaccinated. Right? So, and the immune responses, coronavirus, fortunately, is a much more simplistic virus than HIV, as an example. Right? And probably even more simplistic than influenza, seasonal influenza. It seems to be much more genetically stable. Right? And that lends itself to being able to produce a vaccine very quickly. So I'm very optimistic that we will have a vaccine by the end of next year at the latest, probably sooner. The big challenge we're going to face, the biggest challenge we're going to face in low middle income countries is an issue of access to the vaccine.
I was going to ask you about that. That was my last question to you. So in a country like South Africa, how would we be able to access the vaccine, assuming in the next 16, 17 months one comes around?
So we need to position ourselves. We need to be involved in those vaccine studies to start off with, right? And that puts us in a good standing in terms of being able to take our own evidence to show that a vaccine is needed. The reality is that right now companies are going to need to produce billions of doses of vaccine, right? From a modeling, from an economic perspective and from a business perspective, that's not a good model. You can't develop a manufacturing plant to produce billions of doses for 2 years, and after that you need a few million doses. Right? So there's a problem in terms of that dynamic. So the Gates Foundation, as an example, and many other companies are going at risk, which means that they're investing to produce vaccine at a large scale, even not knowing whether the vaccine is going to work and which vaccine they're going to produce. But there is that investment from philanthropic organizations such as the Gates Foundation to set up those sort of facilities, and hopefully that will avoid what has happened historically when it comes to life-saving vaccine introduction into low middle income countries. There's been a lag of anything between 5 to 20 years before life-saving vaccines that become available in high-income countries are introduced into low middle income countries. 5 to 20-year lag.
And this simply can't be now. I mean,
exactly. So it's really up to society, the global community, to ensure that when these vaccines become available, they become available within a space of 6 months to a year at the most, to countries in the low middle income regions.
Mr. Shabir Madhi, thank you very, very much. I've learned a lot from our conversation, even though we've had a robust exchange, but it's important. It seems to me very, very important that the kind of discussion that we've had should get out into the broader community, because I'm sure as an expert, you must be equally frustrated or more frustrated than me, since I'm not an expert, by how much nonsense is spoken and how many epidemiologists, virologists, and vaccinologists we have in this. I'm sure you didn't realize that your profession had millions, because everybody's but you are one, and thank you very much for your time and for sharing your knowledge with us. Thank you.
Okay, thanks for having me.
Pleasure.